So this clean. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good day. This is Dr. John Bennett broadcasting from Miami. The sun is coming out. We have a presentation today by Ciprian Ionita. He's a PhD from University of Buffalo. I did a presentation with Ciprian a couple of years back on 3D printing in the brain, and possibly we can convince him to do one in the future. Today, Ciprian is going to talk about artificial intelligence in endoscopy procedures. And before we turn it over to Ciprian, Ciprian, could you please get off the screen share? Let's go around and introduce the panelists. You just click on, there you go, Ciprian. I want you to meet all the panelists, okay? That's one of the powers of this platform, is meeting people. Manuel, could you please introduce yourself? Unmute, there you go.
Hello everyone, my name is Manuel. I am from Dominican Republic. Right now I am making the neurosurgery residence in Moscow. Nice to meet you.
Very good, welcome Manuel. Naran, good day. Could you please introduce yourself?
Hi, this is Dr. Narayanan Janakram. I'm from India, but at the moment I'm in Kuwait. So I'm a skull-based surgeon. It's a great effort, Professor John. Yeah, I'm enjoying it. Please carry on.
Yeah, Narana is an big ENT doc online and on the internet, in ENT videos. He's really developing the community well. And he's the only doctor on this panel that can moonwalk. Okay, Gleb. Just unmute, please.
I'm here. Yes, John?
Yes, I can hear. Could you please introduce yourself to Ciprian?
Okay. My name is Gleb. I'm a neurosurgeon from Russia, from southern part of Russia, actually. This is called Rostov-on-Don. And I'm interested in skull-based, neuro-oncology, cerebrovascular, and any interesting thing, like being honest.
Very good, Gleb. Welcome. Dr. Zhang, a new arrival. Hello, Dr. Zhang.
Hello.
Yeah, Kai, could you please? Hi, I'm Dr. John Bennett, the Director of Neurosurgical TV. Could you please introduce yourself to the panelists and to Ciprian? Go ahead, introduce yourself. Where do you work and what your name is, etc.?
My name is Wei-Ming Zhang. I'm come from China.
Oh, what city?
Changsha City.
Welcome.
Province.
Welcome. Ulrich.
Thank you.
Ulrich, welcome. Ulrich, go ahead, Ulrich.
Yes, Sydney, when I am medical students, Cameroonian. Next year, next July, I'll be a resident. I'm aspiring neurosurgeon and hopefully future skull-based surgeon as well.
Very good, welcome. He's from Cameroon, Ciprian. Young Hong, are you there now? Young Hong, I guess he stepped away. Pragnish, Neuroleg, or any other panelists, please introduce yourself. They're learning this technology, Ciprian, where they have to unmute themselves to. People will learn. It's take a learning curve. Okay. Anyways, let me introduce Ciprian. Ciprian, I met Ciprian a couple of years ago. We did a webcast, which the link is on the Facebook page for his webcast that we did with 3D printing in the brain. And today, Ciprian is going to talk about artificial intelligence, an area of medicine which is developing rapidly, and it's impacting neurosurgery. And our community is very interested in hearing Ciprian talk about this. So welcome, Ciprian. It's all yours.
Thank you. Let me share my screen with you guys.
Yeah, could you please tell a little bit about where you're working, etc.?
So I'll bring my presentation as well up. I'm at University of Buffalo, and I'm a biomedical engineering department assistant professor and dual appointment in neurosurgery as well. Our team is located at Gates Vascular Institute. You see it, it's down here in Buffalo. and it's an entire hospital dedicated just to vascular intervention. Somewhere you see in there on the 4th floor, there's 14 angio rooms, all equipped with C-arms that are working 24/7, servicing Western New York population and Pennsylvania, as well as other areas surrounding New York State. I would say our neurosurgery team treats endovascularly about 200 to 300 cases a year. They have strokes, ischemic strokes, at a pace of about 2 or 3 a day. Kind of like this situation created a perfect opportunity for machine learning, because as I will show you, machine learning needs lots of data in order to be effective. The work that I will present today, it is borderline clinical and research. The machine learning part is research. However, the stuff that I'm going to show you in the biomedical or bioimaging markers, that is actually used in clinic today. So with that, I think I think I'm going to start this presentation. And again, this is a lot of research that's going on, and I think some of it is ready for clinical trials and implementation in an angio suite. Some of it, like large vessel occlusion and secondary ischemic stroke events, it is just starting and will require at least 1 year or 2 years of work. All right, so can I start, John?
Yes, please.
All right, so this is kind of an outline of the work that I am going to show today. I apologize, I didn't realize that it's going to be all neurosurgeons, so some of it is kind of basic in terms of endovascular procedures. But then I will dive directly into the imaging biomarkers extraction for intracranial aneurysms. And into that context, I'm going to introduce the machine learning application for image-guided procedures. And the next, I'm going to go to image biomarker extraction for vessel occlusion, large vessel occlusion, and how we use machine learning in order to help the neurosurgeons or develop tools for assistance during the endovascular procedures. The machine learning, it is not intended to actually replace the surgeons or the radiologist or anything like that. It is actually intended as a tool to assist to improve the decision making. And my collaborators are here. It is Dr. Vijay Iyer, who's a cardiologist, but then for neurosurgery, Dr. Elad Levy, Adnan Siddiqui, Ken Snyder, and Jason Davis, who are the attendings, and they have quite a few fellows and assisting them with these procedures. So without further ado, I'm going to just go into the kind of disease that I'm going to talk about today. I am focusing only on image-guided interventions. And in general, these are catheter-based. I'm going to focus on aneurysms. I'm going to focus on some of the large vessel occlusion. And while we work on the AVM, I don't think that we are ready at any point to show yet the results for these malformations. So why endovascular intervention is because it has become one of the most used approach to treat vascular disease. And according to the latest data in intracranial aneurysm compared to surgical clipping, it is somewhere of a rate of 7-to-1. And why do we like this is because we minimize trauma, pain, blood loss, reduce wound complication, and provide short recovery times. All the patients treated at our hospital, they're actually in a great proportion, they're awake during the procedure, and release from the hospital is somewhere between 24 and 48 hours following treatment, for example, of intracranial aneurysms. So what is about this so special about this endovascular intervention is because we are using some sort of X-ray imaging, and while we manipulate devices and catheters remotely out of the groin of the patient. And the devices that are usually involved are some sort of catheters, balloon guide wires, etc. So regardless of the way of the treatment, angiograms and X-rays are the way to look at this treatment of this malformation. So I'm going to insist a little bit on to the aneurysms, and we're going to talk about coiling and flow diverters. And for coiling, why is important to focus on it is that during the treatment we deploy this kind of device into the aneurysm, and this structure, what it does, it reduces the flow into the aneurysm dome and creates a flow conditions, a hemodynamic flow condition, which we are referring as stasis. During this procedure, we induce a large shear gradient onto the flow that activates the platelets. Then it slows down the flow and it allows clot formation into the aneurysm dome. And in this way, it reduces the risk of rupture, and at the same time, some sort of reconstruction of the exclusion of the aneurysm from the flow. So it's key to understand that hemodynamics are used in order to model the flow, to actually treat this aneurysm. And as we'll see, hemodynamics is related to the angiography, and angiography can be used to extract biomarkers, which further we can use to assess some of these treatments. Another type of treatment is a flow diverter. And again, this device is not an actual flow diverter, but it explains the idea. We place a stent-like device across the aneurysm neck. And the structure of the device right here at the neck disrupts the flow, is redirecting the flow through the artery, inducing the same kind of idea, stasis into the aneurysm, reduces the flow. We create conditions for thrombosis into the aneurysm dome. At the same time, the structure of the stent that you see over here acts as a scaffold for vascular remodeling, endothelial cell proliferation, and so far and so on. So both of these devices are sort of related to treatment of the aneurysm by flow diverter, or by modifying the hemodynamics of in the aneurysm dome. So if we want to look on how this devices actually, how the X-ray devices, how the devices look under the X-ray imaging during an angiogram, you see here a coiled aneurysm. Here is a pipeline. If you pay attention there, you kind of see the struts. This is like almost like a finger trap toy. It is a braided system that has about 64 wires. It's very dense. You place this across the aneurysm and neck and diverts the flow away. While coils is pretty self-explanatory, as you see in there. So, well, regardless of how you treat this aneurysm, DSA, digital subtraction angiography, it is a way to go in order to assist them. The latest systems can go up to 60 frames per second. It has a high temporal resolution, which means it's we get a lot of details about the flow of the contrast. It has a high spatial resolution, 200 micrometers, but now the latest, it is about 75 micrometers. And it also, it has reduced anatomical noise, which means it subtracts all this skull information. The bone is subtracted, and we refer to that as high signal to noise ratio. So in terms of the angiograms, it reveals to us the structural basis of the neurovascular disease, but not that much of other hemodynamics flow. So we can look at the stenosis, we can use the AVMs, we can look at the intracranial aneurysms in order to see the structures, the geometry, and so far. But one of the problems, and again, it is mostly structural. What about quantitative and functional information? And this is where our work is focused. And in this context, I'm going to introduce the machine learning and how we can use the machine learning in order to extract those. Here is the idea of physiological flow assessment. As we inject a bolus of contrast through the vascular network, as the bolus goes farther and farther away, it dilutes, it spreads away because of the diffusion and other physical and convection, other physical factors. As it goes farther away, it becomes wider and wider. And the idea it is that if I would know the physics of the flow, and then I would look at how I'm going to inject a contrast bolus, I can actually replicate this phenomena of contrast injection to a T if I have obviously good flow, good computers and so far. But if I look at this contrast in these curves, and I'm trying to go back and say, what is the velocity? What are the pressures into this system? I will not be able to do it. And since I'm not able to do it, then I have to rely on something which is identified as imaging biomarkers. Actually, we're looking at these curves when we parameterize it. We look at things like half-width Fmax, which is mean transit time. It is this quantity from here. How long it takes the curve to go from this point to that point. And it tells us the average time spent by an iodine particle in a particular region. Another way is to look at time to peak. We just go how long it takes the time density curve to get to a certain point. And that kind of like tells us what is the velocity at which the blood enters that region. We're looking at the area under the curve, and that tells us how much contrast gets into an aneurysm, for example. We look at the peak height, and then again, we see how much of the initial flow or how much is diverted away from it. And these are all parameters that we are bioimaging parameters, which we use as features since we cannot estimate the flow just looking at the contrast. And we use all sort of mathematical formulas. We feed it. We use mathematical functions to do that and extract that. Here is the idea of quantitative maps generation. We take the data, an angiogram like you see in here, a whole bunch of frames. And then to do some computational trick, we bin it by 2 by 2 to make it really fast. And then we read every single pixel into the image as it goes in there. At every single pixel, first we're looking if it is this pixel into a vessel? It is not. Are we going to analyze it or not? And again, this is a computational trick to figure out. If it has a vessel, then we fit this data with something like this, with those mathematical functions, and we extract this imaging biomarkers, mean transit time, time to peak, ball area under the curve, and so forth. And we generate this time, these maps. This is actually, as you'll see, these are images. We are images where instead of having now, instead of having the vascular angiogram, now we are having information about flow. This is the time to peak of how the contrast propagated through the system. This is a mean transit time, which tells us various features about how long it takes the contrast to come in and go out from a certain region. This is time of arrival. How fast is the contrast getting to a certain point? This is peak height. How much contrast is in a certain area? And so far and so on, and an area under the curve, and so. So going back to the angiogram, this is a aneurysm in a cavernous aneurysm, I think it was, and you guys correct me if I'm wrong, but it is before treatment and after treatment. It means that it has somewhere in here a flow diverter, a pipeline. Can we look at this and decide this is an optimal treatment or not? Well, I see there is more contrast into the aneurysm dome at the end of the run, but there is, other than that, it's the experience of the neurosurgeon to decide if it is an optimal treatment or not. When we look at 6 months or up to 1 year later, when we look for the aneurysm is gone. So what are the parameters that will predict this kind of outcome? And in general, the angiographic, what you see in this colored image is referred as the angiographic parametric imaging, and it can be used to evaluate the functional nature of the lesion. It can be useful to understand some natural history, prediction of the disease progression, planning of intervention, but the question is, how can we use this information here, pre and post, in order to predict what's going to happen? And this is where the parametric imaging comes handy. And I'm going to start talking about outcomes now. So let's look at these cases. This is a coil case. We have case A, B, and C. And as you'll see, these cases had total different treatment outcomes when we look at them. Here is one of the case, again, and the next one. Here is another case of a flow diverter. The aneurysm is somewhere facing it's towards the back of the screen. This case had 5 aneurysms actually, and they decided to put a pipeline that goes from the top one all the way down to somewhere in here, and treated all 5 aneurysm with one stent. And here is case C, another aneurysm that was treated with a flow diverter. So before I go any further, I need to start using introduce the idea of classifiers, because in order to introduce the machine learning, we need to know outcomes. Machine learning, it is based on supervised learning. You need to input data that is, that was before the treatment, and then some sort of outcome. And we're looking at 6 or 1 year later of this treatment aneurysm, and then we have this classification schema. Class 1, totally occlusion. The white you see in there is thrombus formation, aneurysm totally occluded. Now, class 2, we have some remnant neck into the aneurysm. And class 3 is aneurysm regrowth or incomplete occlusion. In this case, in the side, the center of the aneurysm, we have still complete flow, or in here, it is some sort of coil compaction and the aneurysm starts regrowing. Flow diverters, unfortunately, we cannot use the same scale. The one of the
I'll take care of that. Okay. Mute someone.
Someone has music problems.
Yeah, I'll get it.
All right, so the next one, it is looking at the flow diverters. And the flow diverters, unfortunately, has a different outcome scoring. Here is A's for reoccurrence of the aneurysm. After the treatment, we come later, and the aneurysm is right there. Then we have partial thrombosis for B. We have reoccurrence of the aneurysm, and D, it is no filling. In order for us to start working with this, we created our own schema, and we have a score 1, 2, and 3. And in here, we see for the first case, pre-treatment, after treatment, aneurysm gone at 6 months later. Now, case B, pre-treatment, after treatment, 6 months later, the aneurysm still has some filling. And then we have this case C, where before treatment, after treatment, and finally at the end, at 6 months, there is quite a bit of a filling of the aneurysm. Again, these ratings are given by the neurosurgeons. It's not by any of my technical team or computer scientists. There is nothing that tells us at this point as a treatment if that one aneurysm is going to go this way, score 2, score 1, or score 3. Following the same idea, we're looking at the flow diverter cases. First case, aneurysm before treatment, after treatment, gone at 6 months. Now, the one with a 5 aneurysm treated, when we look at it, there is some residual flow into this one. It's a score of 2. Now, the other one in here, the score of 3, after treatment, 6 months later, the aneurysm is there. And there was absolutely no indication in here or way to figure out what's going on and why one aneurysm fully thrombosed, one is partially thrombosed, and the other one pretty much nothing happened. So what we have done, we took the angiograms of patients acquired, the Gates Vascular Institute. We took about 130 cases. For each DICOM, we obtained an image with the best view of the aneurysm, as you can see in here. And we took different ROIs, region of interest. In other words, we took the data in the aneurysm and measured all these parameters. And we used also some data into the main vessel to to normalize the data. By normalizing it means that we're trying to take into account that different surgeons are going to inject at different rates, and there is no way they are going to use an injector during these procedures to make it uniform across all 4 attendings, for example. During these procedures, all injections are hand injections for these cases, and each one injects differently. They are using different contrast concentrations. They're not going to stop in order to make sure that these injections are uniform. So as I said, there is different surgeons, different contrast injection, no automation, and that's why we take the area over the aneurysm and then we take into the vessel in order to kind of like normalize for the vessel. Now let's look at the data. We start looking mean transit time versus time to peak. These are aneurysm treated versus untreated, and we see clusters. We see differentiation between one and the other. Peak, mean transit time, peak height, again, clusters. I cannot fit this mathematically. When I look in here, time to peak, peak to height, again, very nice clusters. Again, I cannot use a mathematical function to separate them between them. Peak height versus area under the curve, again. And a very nice separation, but no way I can use some mathematics to separate between them. And when you have this kind of data, this is when machine learning comes into place. And I'm going to do a shift, a gear shift, and explain this. When can we use artificial intelligence and machine learning, AI, ML? When we see patterns. And when we cannot use mathematical models. If it's uniform like this and I can find a function that does this separation, I do not need machine learning. But when I have stuff like this that is very fuzzy, we do not know where go or how these elements are separated. Here you have an aneurysm treated with a coil that have this kind of distribution. These are the ones that, let's say, thrombosed. These are the ones that did not thrombose. There is no way I can use a function or a mathematic way to separate it. And then we use machine learning to separate the data. And the third requirement, we need database. We need lots and lots of data in order to be able to learn this function. And I'm going to spend some time on this. So what is it? Well, it's pretty much we're constructing a mathematical model using a data set that contains both input and desired output. And this is key. We need to know the outcome of these patients. We need an expert, a user expert that will go and tell us to classify those aneurysms. This is a score 1, this is a score 2, this is a score 3, and so far and so on. Pretty much, we are teaching the computer to perform a specific task. And if I train a network for aneurysms, I cannot use that network for AVMs, and I cannot use it for large vessel occlusion, secondary ischemic events after thrombectomy, and so forth. Each disease has to have its own algorithm of machine learning. So pretty much, machine learning says there is something that takes data from A into B, takes an aneurysm that has been treated with a coil or a pipeline, and it gave me the score of 1 or 2. What is this function in here? And what we do through a lot of iteration, we learn what is a function that tells us the transformation. So we find a solution by minimizing the differences between the input and output. And I'll explain to you in a minute what is that. So you are aware, the AI machine learning thing is used for self-driving cars, facial speech recognition, game playing, medical realm. It is a little bit more difficult, and we'll go through some of that. Before I go any further, I'll explain to you what is mostly used nowadays. It's segmentation. People are using it to teach how to recognize things in histology, like data. It just goes and makes these contours and differentiate between different features into into a slide. And it's good because it's a lot of time savings for those people doing that. The other thing it is for clinical predictions. In this case, but it's a segmentation algorithm. You have things like for a hemorrhagic stroke or anything like that, and you have a user that goes and by hand has to outline this data. And next time, and he does that for many data sets. And then once you train the algorithm, it will be able to do it by itself. What we are after is that this is kind of simple. Sometimes it saves time and so forth, but we are after actually using the machine learning to guide the interventions, as you will see later. And in order, usually the data is reported like some sort of a receiver operator curve, where we plot sensitivity versus 1 minus specificity, and it tells us if it is good. A perfect tool, imaging tool or predictor tool, will have a square or area under the curve of 1. If it is like this line is pretty much your tool is useless. It's like you're the same, you have the same predictability as flipping a coin if this patient has a disease or not. So what we will see, we'd like to see these curves to be as closer to the to 1 in there. So how is it done? We're using a training set, is compiled, specific to the problem that we do, real world. In this case, we're using lots and lots of angiograms. And then what do we do? You have to have a human expert. And in this case, we kind of go and identify the aneurysm and tell the machine, this is how an aneurysm looks like. And we put this input and that as output to it. And train the network to perform the transformation that it can go by itself from there to go to the here and identify those aneurysms so far. So by training the network, we mean tuning the function, applying to the input data by minimizing the difference between the output and the actual output of the network. And I will explain to you in a little bit. So here is the input, angiograms. Here is the output. The patient is going to have a score 1 or 2 or 3 as a result of the treatment. The question is, who's this guy in here? And in order to find this guy, we need the ground truth labels, which are what the specialist or the expert user will provide. And we compare the output with the ground truth until we find the proper function in here. So after many iteration, we find the right function that will actually, when we come up with the new data, it will predict to us what's going to happen. So let's look at this example in here. We have a toy, we have a function that we think is right, and then the machine predicts, well, it's 60% is a cat, 40% is a goat, or and so far and so on. And we're then taking that and we compare with the ground truth. You made the prediction is a cat. Well, we compare it. No, it's a dog. Go back, retrain yourself. And it just go again. Retrains, looks at the data, now makes another prediction. Cat, 60%, dog, 30%, and all the other things. These are the data that we think it might come. In our case, it's going to be 1, 2, and 3 as scores. Again, we compare it. Well, it's a cat. No, it's not really. It's a dog. Go back, retrain yourself. And we keep going like this until the network, with a very high probability, predicts that this is a dog. And then we stop and say, yes, you're right. The network is trained. And we can move to the next. This process is done over all data and training cohort. And again, data, access to data, many data, it is key in order to train these networks. And so far. So how do we do it here at Gates? We take all this training imaging. These are angiograms, parametric imaging of aneurysm, and they have all this data that I told you. It has mean transit time, time to peak, all these values for before treatment, after treatment, and we also have 6-month outcomes. We have complete thrombosis, partial reoccurrence of the neck, or reoccurrence of the aneurysm. And we train the model, and then we get this learned model. And this is not all. Once we get the model, we want to see, is this model okay? And we use some testing images that were not used to train it. This is very important. We have to have a set of data that is not used for training in order to make sure that the learned model is good. And then we look at it, we use it for prediction, and if we get predictions anywhere above 80 to 90%, we're happy in general. The networks, without getting into the mathematics of it, is just taking data. These are the input. Let's say this is mean transit time, time to peak, and then it multiplies with these variables in here. What it does, it multiplies them, makes a prediction. If the prediction is not right, it goes back and is changing these values by tiny, tiny increments, and then goes back, compares, and it just comes back. And it keeps going into this loop until this values in here, these weights are just perfectly tuned in order to make the prediction. So let's go to our data and getting back to aneurysms. When we looked at the various scores in here, score 1, score 2, and score 3, time to peak, mean transit time, time to arrival, peak height, area under the curve, there is, just by looking at the data itself and the trends, there is no mathematical correlation between them. This is for flow diverters. Now here we put them all together. The data is all over the place, but nonetheless, it is, as I told you before, it clusters. So what do? We take that data, we put it through this whole thing in here. This is how a network kind of like is explained. And every single layer that you see in here does something to the data as it goes and so far, and then it predicts. It makes a prediction. For those of you who are interested, this is some details. We will use this optimizer. We're using GPU accelerated computers in order to make the prediction, and we are using five features, angiographic features. So we look at accuracy using the receiver operator curves, and we use the data 25% for training and validation. Now let's look, what is the accuracy of the network to predict treatment outcome? And our area under the curve is 0.866. In other words, after the treatment, after you put a stent or a coil into the aneurysm, and we just look at the angiograms, we are able to tell you with a very high precision what's going to happen to that aneurysm. And this is key, because at this point we can go and tell the neurosurgeon, you should do something about this patient. Add another coil, add a second flow diverter, because it's not going through to fully occlude at 6 months. And this work was done by Mohammed Shiraz Burawani, and was presented last month at the SPA Medical Imaging. And we are in the process of submitting this a much bigger study in the Journal of Neuroimaging Surgery, JNIS, as well as AJNR. What is our next? It still relies on using a user to go and outline this aneurysm and the vessel. And our next step, it is to implement a completely autonomous artificial intelligence tool which performs data extraction and prediction of intracranial aneurysm occlusion. So in other words, right now, using manual contouring, someone has to go in there and say, this is the aneurysm, this is a vessel, take the data out, make a prediction. And it's suboptimal in the clinical setting, because the neurosurgeons or the rad techs, they're not going to take their time to go and do this kind of things. Maybe they will, but it's a little bit of a time consuming. So what we did, we went and used convolutional network, and usually this is used for facial recognition, and has ability to recognize patterns, and so far it uses more, and it's from this point is more aligned with our problem. So we are going to use this network to do some sort of macro image classification, bounding detection, and pixel by pixel classification, and so far. So we trained a convolutional network, neural network, CNN stands for that, to extract the aneurysm sac and inlet region. And in the same time, we want to extract radiomic features. By radiomic features, usually are referred as imaging features that are so subtle that the human eye cannot tell the difference. And this is what is in general happens for the aneurysm. Those changes in flow are so subtle that we cannot kind of like see them or properly assess them. And what we're doing in here, it is a two-class segmentation problem. Tell me where the aneurysm is, pretty much. That's what we do. And the ultimate goal is to increase the clinical utility of the API processing and also allow it for the support of clinical decision. So the tool it is to be used was a biplane, as you see in here, angiographic arm. And for development, we use 350 DSA acquisitions. We're obviously, I have to state that we're HIPAA compliant with all of this. Inclusion criteria, it was adult patients treated for sacral aneurysm with coil or pipelines at Gates Vascular Institute. And the imaging data, it is done with a biplane, Canon Infinix biplane. And we're not sure yet if this is going to be unit dependent or not. This is something that still we need to figure out how it is. So here are the data, kind of the data that we use. 55 prior treatment, 45 after coiling procedure, for example. And here are the separation: 165 internal carotid, and 98 anterior communication, 35 middle cerebral, 13 basilar, and so far and so on. And also we use true negatives, which means no aneurysm onto the data. Poor imaging was excluded. Sometimes we had patients that were not very compliant or moving too much during the actual angiograms, and stuff like this usually throws the machine learning algorithms a little bit off. So expert user went through all of this data, and he went and contoured the aneurysm sacs, as you see in here, and the vessels. Those were used. We had 250 acquisition for training, 100 for testing, and then we did all sort of things to this data. We rotated, we zoom it, we cropped it in order to kind of like train the network for any possible situation. In such a way, this is what is referred as data augmentation. So in some cases, due to the crops, we went from something that had an aneurysm here to something that didn't have any aneurysms. And following the augmentation, we actually created 1,500 training samples and 600 testing examples. And it's, again, extremely important. Data, it is the most important part. If we don't have data, you cannot do machine learning pretty much in any of this. We use Keras, again, if you're interested in the details. Alexander R. Podgorsak is my PhD student, and he has developed this this feature, and he also presented the Presidium of SPIE medical imaging, where he received for this work a cum laude award from the committee. So again, this is how a network looks like. We have an input, which is angiograms, and what are going to have to output prediction of the data. Network specifics for those interested. We used this GPU again. We use this method in order to train it, and we are using what is referred as transfer learning from ImageNet and so far. And for summation, we use of dice loss on this binary entropy for the loss function. So let's go to the analysis. For analysis, again, we use receiver operating characteristic curve. We use Jacquard index. This, it tells you how well the network finds, for example, data. If the network in red overlaps with the green, which is the ground truth, and you get a 0.4, you have a very lousy prediction for your machine learning. A good prediction is anywhere around 0.92 when your data fits perfectly the machine learning one. And something that is similar, it's a Dye-Sorensen similarity coefficient, which is pretty accurate, pretty close. So similar, and then similarity of the API feature computed with a network or compare with the hand contour regions, and we looked at the percent difference between what the network has extracted from angiograms and what the expert user has done. And we use again Pearson coefficient and so forth. Here are some of the results. Here is the aneurysm untreated. There is a hand contour, and this is what the machine learning looked at it. And this is what artificial intelligence told us, hey, these are vessels. This is what I think it is, an aneurysm. And it's pretty darn close to what the user expert has identified with in there. And again, this is just a computer looking at the angiograms and recognizing where the aneurysm is. And that's what we refer as a good agreement. Again, here is a treated aneurysm with coils. This is what the user expert has outlined, and this is what the machine learning has done. Despite being coiled and so far, it was able right on the money to go and say, this is the aneurysm in this image, and this is where I'm going to extract the information about the angiographic parametric imaging. And again, pretty good agreement and so far. Despite motion artifacts and so far, the machine was quite well at identifying there, as well as other high attenuation structures, not a problem for the machine. So another example, treated. This is the aneurysm. This is what the user expert has outlined. This is what the machine learning thought it's an aneurysm. And again, did pretty good between that. Despite having a catheter in there, the machine totally ignored it, was okay with just going only for the features, the right features into the image. So looking at the area under the curve, pretty close. We can do better on this. Again, area under the curve of 1 for a receiver operated curve. It is a perfect imaging tool. For the vessel area under the curve, it's a little bit lower, is because small vessels fails to identify some of those. So here are some of the results. Pretty good area under the curves, pretty good Jacquard index. Again, this is comparing what the machine thought is the aneurysm, this and the confidence intervals as well in here. And this is in the proceeding of SPA, and we have already a paper pending in the American Journal of Neuroradiology with the same topic. Dye-Sorensen coefficient, excellent agreement again between the network and the manual user. And for the vessels, the periphery right here, it is pretty poor. So that's where we kind of like fail. It fails to recognize some of these features, and there is room for improvement for that. So when we look at the comparison between expert user and the machine learning, and say what is the accuracy, what is the difference between extracting, let's say, mean transit time between the user and the machine learning, and the difference is 0.2% between the machine and the user. In other words, the machine learning algorithms are right on the money to extract those angiographic parametric imaging from an angiogram. So it can take all this time to peak, mean transit time, area under the curve, and again, these were the parameters that I showed you before, can predict with a very high accuracy what's going to happen to the aneurysm immediately post-procedure. I mean, you put the coil in 30 seconds, the machine will predict this aneurysm is going to occlude or not. And that is where we're kind of like try to push this this research. And again, strong association between the user and the machine learning showed in here. So our network performs non-inferiorly to an expert user. and a lot faster. It's literally a fraction of the seconds in extracting some of these features, and it does. Um, the API takes about 20 minutes, and I'm sorry, it takes about 5 seconds once you use a train network to do this. So again, we image a clinical workflow where follows the placement of an angiographic device. Angiographic parametric imaging could be carried out, and compute values passed on the secondary network to predict a clinical outcome. Revision surgery could be carried out with the patient still on the table instead of following at a 6-month period. This is the whole kind of the idea. Patient comes in, is treated, all these parameters get into the aneurysm location. The machine recognizes where the aneurysm is, extracts those features, puts it back into another network, and then it predicts what's going to happen with that aneurysm with a certain confidence. It will give actually percentages. It has 90% chances to occlude or a total occlusion and so far and so on. And based on that, the surgeon is still the neurosurgeon's decision. What I'm going to do next? Am I going to trust the network and do something more about it, or just trust my gut? Ultimately, the decision, it is still the one of the neurosurgeons. Now, I'm going to go to the next step, and it's stroke due to large vessel occlusion. Here is an example of a person. It has a large vessel occlusion somewhere here in the MCA. In order to treat that, nowadays at our center, we use thrombectomies. A device is placed over the clot. It engages the clot, and the clot is pulled out. You see in here frontal and lateral views. Before treatment, there is like no perfusion into the MCA region. Once the clot is removed, we have a nice perfusion in here. This is the same thing for the lateral view. When we do the parametric imaging, this is pre-treatment. There is delay in the contrast arriving this area. Once we remove the clot, you see all this area being reperfused. And the idea is that when we look at the angiograms in here, we see there is something, there is nothing almost there. However, the parametric imaging kind of tell us maybe it's something wrong in there as well. So, and one of the problems is that as we pull this clots out, fragments of it might break, and they go into smaller vessels, and then they can create secondary stroke event. In the worst case scenario, you pull the clot out, it will break somewhere in here, and instead of going into the MCA territory, which was initially imparted, now you have something flying into the ACA, and you actually end occluding or causing an ischemic event into an area that was unaffected initially. So kind of this tool is aimed at complications after thrombectomies. And following the same idea, we're taking this input maps, we put them into a network, and now we have a ground truth level of the infarct core. Where is this coming from? We have a whole bunch of patients that went through thrombectomy, and we have 48 hours flare data from MRI. And we can use that data in order to create these labels in order to train the network to recognize these infarct cores. We want the network to predict the infarct core right during, or new infarct cores during the thrombectomy. So we take the MRI data volumes, and obviously the some of this data is not the best. We're recombining it, and you see it is full of artifacts, but we're not quite interested in all this artifacts, so we can still work with it. And we're looking for where the infarct core is in a simulated frontal view and a lateral view. And we take this data from here and we co-register it with the actual angiograms. And again, this is what goes into the network. This is what we would like the network to predict. We have to hand label all this data and so far. So we go into the MRI and we have an expert user goes by hand, and he creates this this kind of maps. Then the data is taken, and it's we take the views. Here we have two cases of parametric imaging. You kind of like can tell there is something quite not right in this region just by looking at it. You know that the things are not going too well. And then here are what we took from the MRI and co-register with the actual parametric imaging in this case. And this is how it looks like. And we use this data in order to train a network. And once we train the network, again, this is on data in the angio suite, no CT, no MRI, as if it is, where the network says there is an infarct here and there is another infarct there, something along those lines. And we compare the two data. It is a pretty good accuracy between the two. Again, I want to point out that this is initial data. We just started doing this, so the predictions are not quite well. We need to work a little bit more, and we get some errors which are expected, some differences, because also the MRI is taking 48 hours after the actual thrombectomy, so maybe some differences in there as well. The ROC with unnormalized, just simple data. We just started doing this for a few hundred cases, under 100 cases, actually. It is a little bit better. It is at 0.639, but we have done nothing yet in order to account for some of the artifacts and physics of it. So this curve can only go up from here. So I'm going to end with some discussions, and this presentation employs a novel approach to predict at the time of the treatment which intracranial or ischemic stroke due to large vessel occlusion patient uttered risk of a subsequent treatment failure. And as of now, there is no quantitative tool to assist the neurosurgeon during the procedure. We're not talking here about a post-procedure CT perfusion or a post-procedure MRI. We have some computational flow dynamic tools which have been proposed, but those are time-consuming. And what we have demonstrated here is a new features for a tool which can use the angiographic parametric imaging and the machine learning to answer this need. And I'm sorry about this busy slide, but our ultimate goal is to create a completely autonomous, independent tools that could be used in the angiogramming suite in real time to predict the outcome at the time of the treatment. We do not care if you can go and 6 months later find something about that aneurysm that is occluded, not occluded, and you have to do something about it. We want to minimize all that effort in one step. What is for us? Well, we're looking for collaborators because we need data. We need to apply this in all sort of situations. It is to implement a technical efficacy and accuracy. This is absolutely important for us in order to start clinical trials for something for a tool like this. And I hope if it is successful, this approach could become valuable to assist the neurosurgeon in making decisions during intracranial aneurysm endovascular treatment. And I think endovascular intracranial aneurysm is a pretty good candidate. AVMs are another candidate that we are focusing on. And ischemic stroke, it is challenging, but it's not impossible, as I showed in there. So the idea is best on real-time recommendation by machine learning algorithm. This neurosurgeon could adjust their treatment to improve the occlusion rates of intracranial aneurysm and patient management post-thrombectomy. The thing is, this is key because if clots break during thrombectomy and they go into the smaller vessels, there is not much you can do about it. As of now, for small vessel occlusion, I don't think there is any kind of endovascular therapy. But as we talk to our neurosurgeons, if you give us a tool and we see it at the time of the treatment, that might change. then again, this is debatable, but definitely as far as concerns the post thrombectomy management of these patients and how you treat them in the ICU, and so far can be adjusted using a tool like this. So this is just an example. Depending on the device selection, they could add a second flow diverter, or add more coils, or combine the flow diverter with a coil to optimize the embolic conditions to the aneurysm. And this is my team. If you have questions about technical part, like what goes into the network, how is the code written, the guys in green are the masters of, are the programmers. All the data that you've seen, it has been this lady here that every day goes into the PACS and archives hundreds and hundreds of cases. And all this work is not possible without the neurosurgeons, obviously. They are the one that are actually leading, and they are giving us the problems. This is how in general this team works. They are identifying these problems, they present them into the M&M weekly meetings, or into endovascular conferences, which are occurring weekly. The entire engineering team is there with them. We're listening to their problems, and then we go to our labs and computers, and we try to fix it the best we can. So thank you, guys, and I'm open for questions.
Very good. Thank you very much, Ciprian. Before we open up for discussion, let me just say a few general remarks. This is a realization of exactly why I love the platform of video, because we're able to put together people from areas of the world like China, which is very big in artificial intelligence. And I'm really looking forward to establishing a neurosurgical community, Ciprian, in China. And that is going to be key to getting data, I feel, because we've run into other neurosurgeons that specifically go to China because they can get numbers of patients. And you said you need numbers, but hopefully we'll get things going with the Chinese neurosurgical community in getting getting patients for you guys. But okay, so let's open it up for comments or questions. Okay, anybody in the panel? It's open. Let me get you off screen share, Ciprian. Okay, I'll get you off there. Hold on.
I'm going to stop share here.
Okay, there we go. Okay, stop share my share. Okay. Okay, any questions or comments for Ciprian? Especially the Chinese neurosurgeons. That's huge in China, correct? Young Hong and Dr. Sen? Can you hear me, Dr. Sen? Hello? Well, you may have stepped away. Any of the Chinese doctors, are they still here? Dr. Zhang, do you have any comments? Hello? Yeah, you have any comments or questions for Ciprian?
Thank you very much for the professor excellent topic.
Okay. Yeah, this is just a start. Is this the first study you've been involved in, Ciprian, with artificial intelligence?
We're mostly focusing on things like angiographic parametric imaging, and we've been at it for quite a while. And we try to look at mathematics to answer the problem, and we've not been very good at it. Okay. And then the next, like a year and a half ago, at the Radiology Society of North America and so far, we started looking into this machine learning algorithm, and we said, you know what? We see the clusters, and definitely there are trends. Then maybe the machine learning, it is a way to go. Okay. And it is nothing. It's nothing like really very complicated about it. Right. If you know your programming, you have programmed for a while, and my team and I myself programmed for the last I don't know, 25 years or so. It is very easy.
Okay.
there's tutorials, there is all sort of things online that can guide you. It is a very steep learning curve. In a few months, I would say you can get yourself up and running. And it took us about 2 years to get where we are right now.
It seems to be being used in all areas of medicine. Especially radiology, it's tremendously successful.
Yes, segmentation is just very, very good. But we were, again, driven by these neurosurgeons. We were interested in doing something during the surgery. They pretty much, like Dr. Siddiqui and Dr. Eva, who are experts in the field, they don't need to know where an aneurysm is. They don't need to know to tell them this is an AVM. But you can actually have them look at this fine features into the flow that, as a human, you cannot differentiate them. There is no way just looking at the angiogram to be able to tell exactly what is going to happen in the aneurysm. And this is, I think, where the strength of this approach comes into place.
Yeah, I was surprised looking at some of the studies that you can't tell by the size of the aneurysm how dangerous it is. I was surprised at that. And this is a way to measure the danger factors of an aneurysm, partly?
Yeah, yes. We did not apply machine learning to this because there is a better tool for it.
Okay.
It's called computational fluid dynamics.
That measures the flow inside the aneurysm?
Yes, and that you just take the geometry, you put it in a computer simulator, and it will predict the risk of rupture. And it can use also patient history and so far in there. Mm-hmm. That takes time, though. You need a couple of hours for the software to run, to do all the calculations and so. As of now, it cannot be used into an angiographic suite for real-time prediction.
Okay. Don't worry, Ulrich. I understand probably less of artificial information than you do. So we're in the same boat there. We have a medical student here, so he'll be learning this from the very start. I know that I want to brush up on it. Sen, how are you today? Sen, he said, how you doing, Sen? Move your camera. We want to see your beautiful face. There you go. There you go. I'd like you to meet Ciprian and Ionita. Zen is a neurosurgeon from Zhenghao, China. Did I pronounce that correctly, Zen?
Hello.
Yeah, he's from Zhenghao, China. And have you done any work in artificial intelligence at all? Or have you heard of any work? Because I know that China is very big in it, in artificial intelligence. They're probably one of the leaders, right? With the United States or up top. Do you know much about that, Zen?
AI in China?
Yeah, do you know much about artificial intelligence? I know very little, and Ulrich is the same, probably. Do you know much about artificial intelligence, Zen? No, can you hear me okay? Have you worked with any neurosurgeons that use artificial intelligence? I'm sorry, it's a language. I think
maybe I can answer you now.
Okay.
I need.
Don't worry about it. Don't worry about it. I know that it's a language thing sometimes. Anyways, Zhang, any more questions or comments? Young Hung, I think he was on call and he left. In operating and coming back. Okay, very good. You know, this is, I know that you know this area is going to expand, Ciprian.
Yeah. And
probably, is this the only AI study going on in Buffalo now, or do you know of others going on?
Oh, there's a lot of them.
Yeah.
If at the last conference, if you didn't do in medical imaging, we were on last 2 weeks or 3 weeks ago. if you didn't do machine learning,
Forget it.
you wouldn't understand anything. So every single application that we've seen in machine learning, everywhere from glioblastomas to COPD to cardiac disease includes some machine learning. It is a huge move
Growing.
towards that.
Well, I'm going to send you a link to a webcast we had with a Chinese businessman from Beijing that made a program to read chest x-rays, and it's being largely used in Beijing, which has a very high pollution index, and they don't have enough radiologists to read just chest x-rays. So they have artificial intelligence read thousands of chest x-rays to pick out the ones that are dangerous to be screened and to be checked again. But I know they're using that a lot for chest x-rays in Beijing, to go through thousands of chest x-rays to pick up suspicious lesions.
Yes, indeed. Mostly it is for, as I said, for segmentation, for identification of certain lesions. The other thing is what I refer as the radiomic features. Those are quantities measured on images like we do for angiographic parametric imaging. Those that are anything we cannot perceive them. They look at the things like entropy, fractal dimension, and so far onto this, that they're all mathematical concepts, and they put into this machine learning and try to make predictions. One piece of advice is that to pay attention to this machine learning algorithms very closely, because they might actually fool you if you're not careful.
Right.
If you do not know what you're doing, and it was this example that was a machine learning algorithm trained to look for tanks, and when they looked into more details, they found out that the actual algorithm was highly trained to identify trees.
Trees.
Yes. So if you do not not familiar with it, and you do not know what you're doing, you can you can get garbage.
So as far as the programming, you mean? How putting
The programming part. So and we went through this in the initial part. We were getting like this incredible area under the curves, and we were all happy. We discovered this and that, and then we figure out that the machine was looking for the wrong features and so on. So it is a process. Human anatomy and especially X-ray images are quite complex.
So granted, as artificial intelligence is probably the most advanced in probably, well, for sure, radiology, probably pathology too, reading slides, etc.
Yes, I just saw the work of I forgot his name, Fuke in New York City, where they have all this database of histology slides of tumors, enormous amount of data, and they are just going through various machine learning algorithms and trainings in order to be able to identify malignant versus non-malignant tumors. And he was pointing out how difficult it is for a pathologist to go through so many slides.
Yeah. It kind of automates the reading of a slide.
Yes, and
well, like you said, you first you screen it, and then a human has to kind of make sure it's not looking at trees.
Yeah.
You got to kind of overlook the algorithm, correct?
Yes, and once it's trained, it's just amazing. And there's quite a few FDA-approved machine learning algorithms. And what you need to know is that once you go for a FDA, you cannot retrain your algorithm.
Oh,
so
really?
For every single retrain or actuation of the algorithm, when you update those weights,
you have to apply again for an FDA approval.
Oh, okay. Well, they really don't, it's a new field, so they don't know how to regulate it. How can they regulate it if they don't understand it?
Yeah, and the other thing is we do not know some of these algorithms, how they work. It may be that if you train of the algorithms on one specific, let's say, Western New York population, and then you take it and you apply it to Japanese population,
Yeah.
you know what? It might actually not work as well. So we gotta look at all these variants and make
Right.
sure that these algorithms work properly. And again, data is key to all of this.
You know, some people say AI will take over doctors' jobs.
We will never take over the doctor's.
Well, yeah, like you say, someone's got to overview the system. Otherwise, we'll be treating a tree.
Yeah.
So, Ciprian, thank you very much for coming out, and I hope to have more. And I put our channel at your disposal of your research and department, and I hope to do more. And we're also maybe a good access point for studies that you may want to run. Hopefully, because there specifically was a neurosurgeon that was doing a study on tumors that went to China because he could get numbers of patients in his study. And I'm sure the closer we get into the Chinese neurosurgical community, the more we'll make contacts and will be an access point for people like you, researchers that want to get numbers.
Yes.
And so I think if we just get solid communication together with our community, research community, I think we may make some progress.
Absolutely, yeah. Again, and just to summarize it, artificial intelligence will not be the answer to everything. It is for those who cannot find a mathematical model or situation where we see patterns, and the cases where we have lots and lots of data.
Very good. Okay, Ciprian, I'm going to sign off now. You're welcome to stay, and thank all the panelists for coming. And we'll see you next week.